again. So I'm going to talk to you also about Denosumab, but then a summary of the studies that we've been performing at the Leiden University Medical Center. I think before kicking off with the presentation, I think it's good to also highlight the differences between the way the care in the Netherlands is currently being done and the kind of hospital we are, because it might change also how we look at the data in comparison with what Alison just presented. So we're a large referral hospital for Fibrous Dysplasia McCune-Albright Syndrome. Also means that we have a very large orthopedic outpatient clinic where a lot of patients are being seen, especially also with monostotic lesions. So when we compare our cohort to the cohort from the NIH, we see that their cohort is more severely affected, and we have a mix of cases where also a lot of monostotic patients are present. In addition, we also have a very large cohort of craniofacial fibrous dysplasia, also isolated craniofacial. So that also means that in terms of bone turnover or severity of disease, there are a lot of changes. So I think that's good to keep that in mind when I'm presenting on our results. So our patients come in every year at least when they're affected, because they're under regular clinical care at our hospital. And compared, of course, to the US, everything in the Netherlands is quite close. So I think the largest amount of kilometers people have to travel to visit us is a maximum of 300 kilometers. So I think that's more easy to do and also more easy for us to perform these kinds of studies. Although for people in the Netherlands, even 300 kilometers is sometimes quite a lot of travel. So what I'm going to present here is basically the proprietary work that we did with 3 of my PhD students, which I think is good to highlight. So one, the first basis of the studies were done by Bas Major. He was in training to be an orthopedic surgeon, but unfortunately he switched to general surgery. But he did do a lot of studies in the meantime. So in our cohort of patients with adult patients who were treated with bisphosphonates for quite a long period of time, we saw that the bone turnover markers were still increased and they were still in pain. And that was one of the main entrances to start them on the Denosumab. By that time, Denosumab was available in the Netherlands since 2012 for osteoporosis, which means that the osteoporosis dose was with Prolia, which is 60 milligrams. So we first started them on the osteoporosis dose because by that time there was no experience at all with Denosumab in the use of fibrous dysplasia. And what we saw in terms of bone turnover markers are these 2 graphs. So some of the people we gave a 6-monthly dose, and then we saw in between, after 3 months, there was a steep decline of bone markers, even normalized in a lot of patients. And then when they came back for their second dose at 6 months' time, which would be the normal osteoporosis dose, we saw that the majority of them had gone up again to pre-treatment levels, and some of them even exceeded the pre-treatment levels. When we dosed the Denosumab 60 milligrams every 3 months, we saw an ongoing decline in bone turnover markers and no signs of increase anymore. So that led, at least for us, to change the dosing schedule instead of 6 months to 3 months, but still remaining on the 60 milligrams. During the period of time, we also, the sodium fluoride PET scanning was made available in the Netherlands. Sodium fluoride PET scanning was already touched upon by Alison, but it's a very good way of quantitatively measuring bone activity, and it also allows you to follow up bone activity during the period of time. For instance, in patients who are treated for lymphoma or for malignancies, the PET scanning is also used to define treatment success. So we also know that when we use just plain bone scintigraphies, especially when we're still using bisphosphonates, you don't see a lot of changes. And also these 2 are 2D images, so you can't really look at the change of volume of a lesion and also not really appreciate what happens inside the lesions. And the PET scanning does make that possible. So what we saw on the sodium fluoride PET scanning was not only that we saw a decrease in activity, like the NIH trial also showed, but we also saw in people who were taking the drug for a longer period of time that the lesion size decreased. And so these are two pictures from that particular study that we did, that we saw that in two patients, adult patients, so the woman with the rib lesions was already above the age of 70, and she also had a restriction in her pulmonary function due to the size of the lesions. We saw that there, after 4 years of ongoing denosumab use, so 60 milligrams every 3 months, there was a decrease in lesion size. And the same was accounted for in the woman with the leg that I'm showing here. She also is taking denosumab for 6 years now, and we also see an ongoing decrease in lesion size in that case. What we also saw, because this is the sodium fluoride PET scanning of the same woman with the 3 monthly doses of 60 milligrams, we not only saw a normalization of the bone turnover markers, but also a very steep decrease in bone activity. You still see there is a still very active lesion right in the lower part of the upper leg, but the rest of the lesion really became less active. And this was also accompanied by the fact that she notices not only a decrease in pain, but during the night she often felt that her leg was more warm than the other leg, and that part also decreased a lot. And she's still currently still taking the medication because it increased her mobility. She doesn't take any opioids anymore. And in this case, this was really a success. But then again, this is only anecdotal evidence, of course, for observational studies. Then we also had a look at the specific response in bone turnover markers, especially also in the patients who were stopped. So what we saw in the patients who were pre-treated with bisphosphonates, we saw that halfway the treatment everybody was low with denosumab, and then at the end of treatment we also observed a rebound phenomenon. Not as severe as the cases as just presented in the presentation before, but then again, keep in mind that we see a different population. So there was one lady who really went up high with the bone turnover markers, and also had a mild hypercalcemia. However, the hypercalcemia was not symptomatic and also gradually declined again after weaning off the rebound period. No one of the patients ever needed bisphosphonates to further treat the rebound phenomenon. But nowadays we also, because of the different types of use, and also we now know, also again from the osteoporosis study, that the longer you use the denosumab, the more severe the side effects in terms of rebound phenomenon are, that we are using bisphosphonates as an exit strategy to stop patients on denosumab. So this was not intended for you just to read it, but just to show you that I think one of the main things we also need to stop doing is presenting case reports into literature, because these are all the case reports that are currently being published on denosumab. And as you can see, a lot of the case reports only have 1 or 2 entrances. Of course, the first 2 are always important because that's the first presentation for the use of the drugs. But after that, I think we really should try to attempt to at least exceed above 10 or 15 patients when we're going to report on something. Because I think in the last year, when I was trying to make up a summary for how far we are in the research community for denosumab in fibrous dysplasia, there are really more than 50 articles being published, but when you look very closely, you see that the majority of them are only presenting 1 case, and most often in the most extreme form with a very rare side effect or with a very extraordinary response. And that kind of dilutes the way I think and how we're thinking about the disease and handling the disease. So there are currently 2 ongoing trials on denosumab. So we've already heard from Alison about the NIH trial. So I'm going to shortly share with you the denosumab for pain and FDMAS trial that we currently are performing in the Netherlands. It's a multi-center, placebo-controlled, investigator-initiated trial, which is really a pain in the butt, I can tell you, to organize that. There are so many rules, but there's also the reason that we're only doing the trial currently in the Netherlands, because otherwise it would have been too difficult to do it at the moment. So we are targeting adult patients with fibrous dysplasia, McCune-Albright syndrome. They need to have a FD of a pain score above 4, and we need to make it solid that the pain is coming from the FD lesion. So that means that in a lot of cases, patients are first seen also by our orthopedic surgeons to make sure there's no impending fracture or mechanical reason why they're in pain, because otherwise, of course, the drug will not work. And if we agree with each other in our multidisciplinary team that the pain that the patient is experiencing might derive from the FD lesion, then they are possible to enroll them into the study. So in this case, we are not using the 60 milligrams of denosumab, but the ex-Giva dose, the 120 milligrams. I wanted to do the study with the 60 milligrams, but it was really difficult to make the placebo because the 60 milligrams is in a pre-filled syringe. So that meant that we had to make pre-filled syringed sodium injections, which was really too expensive for the study. And the denosumab 120 milligrams is something we can make in our own pharmacy, so that's why we can blind it in this case. We give 3 monthly injections, it's double-blinded, and afterwards, after 6 months, because we designed the trial in collaboration with the Dutch Patient Association, and of course, with randomized controlled trials, it's very difficult if people know that they are getting a placebo drug. They might not want to participate in the trial. So that was the reason that we designed an open-label second half, where patients who are still in pain can transfer to denosumab injections. And then they are also extensively followed. So our primary endpoint was the difference in maximum pain score after 6 months. But we're also targeting other endpoints, of course, like we're measuring the quality of life, physical activity, because that's also something that we notice with a lot of our patients, is that in pain scores, they're still telling us they have a pain score of 5 or 6. But in the meantime, they started to do household chores again, or doing the groceries, or bringing their kids to school, or were decreasing already with their pain medication. And that is all otherwise very difficult to target within such a trial. So we have incorporated that as well. We are evaluating the possibility of a neuropathic component of for the reported pain, also because of the discussions we had in the consortium with the Pain Detect and the findings of the other studies. We, of course, evaluate the use of analgesics, changes in mobility. We are going to look at the effect on the lesion size, but also on the bone mineral content of the lesion and activity, of course. So these are just a summary of some of the things that we're looking at, but we hope, of course, that we will get a lot of extra data because it's a randomized controlled trial, we need really a lot of patients, so we're going to include 66, I think. Oana? 80? 60? 82 patients, so it's even worse. 82 patients with symptomatic fibrous dysplasia. So we have one other site within the Netherlands. Although the Netherlands is small, not everybody from the southern part of the Netherlands would like to travel up north. So we have one additional center in the southern part of the Netherlands. We also will include patients, and the rest of the academic hospitals agreed that they would refer patients for the duration of the study. Which I think is also a great step forward in the care and especially in the science for this disease. So this is basically how we designed the study. So of course patients will come in, get the shots of the denosumab, and then we will do extensive blood works, questionnaires, sodium fluoride PET scanning. And this will repeat it throughout the study. And we will perform sodium fluoride PET scanning before the entrance, of course, because we use it nowadays in clinical care within the Netherlands instead of a bone scan. And we do it again after 6 months. If patients will continue using the medication, an additional bone scan is being done at 12 months to evaluate the course of the disease and to have a look, of course, at bone activity. And all these parameters will be assessed in the meantime. Of course, there's an extensive team involved in the study, so this is just to highlight everybody who's working. So we have a very important multidisciplinary team, which includes the ophthalmologist, Stijn is also present here, but also our radiologists, nuclear physicians, pediatrics, oral maxillary surgery, and we have a very close collaboration with different hospitals within the Netherlands, especially also for the basic science part with the Amsterdam University Medical Center. So I think for this part, I'm open for any questions or suggestions.
Thank you so much. Any questions for Natasha? Turn it on. I had a very simple question, actually. So, FDMAS is one mutation, but many diseases. And it seems all of the dosing is based on weight, not on extent of disease. Would you like to comment on that?
If we should do a weight-adjusted one.
No, just Alison's is using a weight-based process. You're just doing a standard dose. But you can have FD in your little finger, or you can have FD everywhere. And that's one of the challenges of FD.
Yeah, so in the beginning because also in our population we have some, in the beginning, the first studies we did, we had also some people who were very severely affected versus the monostotic patients. Of course, in terms of bone turnover markers, the ones with the high disease burden will have higher bone turnover markers. But we did see normalization in some patients with very extensive disease after one single shot of Denosumab 60 milligrams. So that's made us to believe that probably the disease extent is in some cases not the only main driving thing, and there's an individual response, and what drives that individual response is something I think we should look at. Might be disease activity, might be the aspect of the lesion in combination with the extension of the disease.
Yes, hi. Looking at all this, if I were a patient and had the money, I would seek off-label use of Denosumab. It's an approved drug.
Yeah.
So what stops a patient that has the financial capability from convincing a doctor to prescribe Denosumab to them?
It's a very good question, because in the Netherlands I'm also allowed to provide it off-label to patients. So that was also the basis that we could look at the patients who were using it for a longer period of time. But what I found very remarkable, and that was also something that we discussed with the patient association, is that when we explain the reason why we want to perform the study, almost every patient says, okay, I will participate in the study. And that was also the reason why we only give them the drug for 6 months, placebo-controlled, and then they will proceed open label. Because they know it's very important, not only for them, because there's an extra, of course, that we know that they are their own controls, but also they would like to give something back for the community, because a lot of patients have been suffering from pain for a very long time. And they also know, with all the change in legislation, that something that I can prescribe now as off-label drug might not be available in 2 or 3 years. So you never know. So people are very willing to collaborate as long as they know that everything has been designed in collaboration with patient association and they feel heard.
I have a question regarding the effect on Denosumab for when you showed the rib that had a reduction in volume. I know that in your studies you guys talk about the fluoride tumor volume as the volume measurement, so like the volume of the lesion that has sodium fluoride uptake. Did you guys also look at the volume of the total FD lesion from CT?
Yeah, we did. So we also saw that in these patients I just highlighted that the total volume on CT decreased. So there really are a lot of parameters you can derive, of course, for sodium fluoride PET scanning. Some of them are very relevant just to perform research with. The other ones are also very useful in a clinical setting to define response on a treatment. So we try to combine it, but it's a very Your nuclear physician and the radiologist have to spend a lot of time on reading the scans. So we're somewhere in between now. When it's not a study, then they will just give us the SUV max changes. And when we're doing the studies, of course, Oana is going to learn how to measure everything, but that we really need a dedicated people for it.
Yes, you had mentioned that your population is significantly different than the NIH population because of the large number of monostotic patients. And I would make the statement that many of the monostotic patients can be completely and permanently treated with surgical removal of the monostotic lesion with conventional orthopedic surgical techniques. Then they would not be subjected to medications that have unknown long-term side effects as well as immediate side effects, et cetera. So I wonder why your studies are polluted with monostotic patients who really are not the patients who are in most need of the medical management.
Yeah, but sometimes the lesions are too big and the surgery is too extensive, so then it's not a possibility. And you're absolutely right. The majority of monostotic patients doesn't need any treatment at all and just a proper diagnosis. So what we're seeing here, of course, when we include for the Denosumab studies, the patients who are included there, I think it's about equal with monostotic and polyostotic, which is different to our full cohort. But these are the patients who cannot receive surgery, and you would like to offer them something else as well, if it's needed, of course.
I have some questions from Zoom land. So first, is this study only for the Dutch population?
No. But financially, it's more difficult, of course, for people to come from abroad. But it is possible for foreign people to join in. We're currently screening a woman from Belgium to see if she can participate.
And then this person says, or Hans says, if you want to do 60 milligrams versus placebo, you could use the 120 milligram formulations and just waste the first half. Hans.
Yeah. That also makes the study more expensive. Yeah, it is already a really expensive study to do an investigator-initiated placebo-controlled trial. And then if you have to throw away half of the formulations with other legislations, that's really difficult. So that's why we decided on the 120 milligrams.
Oh, thank you. Natasha, thank you so much.